Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic: the treatment of rheumatic diseases for MRCP, disease-modifying anti-rheumatic drugs, or DMARDs. So, the treatment of rheumatic diseases is complex and extensive. There is no single cure for the rheumatic diseases which we have discussed in previous episodes. Symptomatic control is part of the mainstay of treatment, and this is done with analgesics such as non-steroidal anti-inflammatory drugs, and these include ibuprofen, naproxen, and some other drugs, including the COX-2 inhibitors, which we will discuss in a future episode, as well as corticosteroids. Immunosuppressants include the disease-modifying anti-rheumatic drugs, or DMARDs, which is what we will discuss in this episode, as well as the biologics and the newer targeted synthetic agents. Corticosteroids can be given in various different routes, including oral, topical, intramuscular, intravenous, and intraarticular, depending on the scenario and the clinical context. They are used during induction of new therapies, as well as during acute flares. It is preferable, however, to avoid long-term use due to their many side effects, which we will discuss. And for this reason, oral steroids are usually prescribed with a proton pump inhibitor, such as omeprazole, as well as bone protection, certainly calcium and vitamin D, as well as alendronic acid, particularly in the long-term use. And a classic example of this would be GCA. Side effects of steroids are multiple and quite a long list. Not all of them will be present in every patient. Some of them, to name a few, are osteoporosis, particularly with long-term use, steroid-induced diabetes, or indeed worsening of existing diabetes, weight gain, including central obesity, gastritis, which is why we prescribe the proton pump inhibitor, Cushing's syndrome, which some of these symptoms and signs are part of, easy bruising, immunosuppression leading to increased infection risk, as well as cataracts, and there's plenty more besides these. The DMARDs are a heterogeneous group of drugs which work to suppress and or modulate the immune inflammatory system, by which we mean inhibiting cytokine-mediated inflammatory damage, which is seen in the rheumatic diseases. The onset of these drugs is weeks to months, so this is a classic example where one may require a short course of steroids in order to bridge while starting a new drug. They are not designed for immediate symptomatic relief and are usually used in combination with NSAIDs or steroids, particularly when one is starting a new drug. They may also be used in combination with other DMARDs, as well as the biologics, which we'll talk about in the next episode. There are several factors influencing the choice of a DMARD, or indeed any drug, including the stage and severity of the condition, side effects versus benefits, patient preference, comorbidities, as well as the availability and cost. So now we will go through some of the DMARDs that are commonly used in the treatment of rheumatic diseases. Firstly, methotrexate. So this is a competitive inhibitor of dihydrofolate reductase and is used in the treatment of rheumatoid arthritis and lupus as a couple of examples. The monitoring requires several aspects. So first of all, you would do a chest x-ray prior to treatment. This is because of the risk of methotrexate pneumonitis. Folic acid, which is given 5 milligrams weekly, should be prescribed alongside methotrexate, which is also given once weekly. The monitoring of the blood tests is 2 weekly until 6 weeks after the last dose increase, and then monthly thereafter until stable for 1 year, and then 3 monthly. Side effects are wide-ranging, so some of the most common are an upset stomach or a sore mouth, and the ones that we fear the most And the reason for our blood monitoring are a low white cell count, as well as increased risk of infections, and they may present with a fever. The other aspect to look out for, and the reason that we monitor their blood tests, is liver impairment, particularly if someone is drinking increased amounts of alcohol. And indeed, it's really important to take a thorough alcohol history before considering prescribing methotrexate. The risk of methotrexate pneumonitis is there as well. And it's important to note that this drug is not safe in pregnancy and breastfeeding. Sulfasalazine is our next drug. The mechanism of this is unknown, and it is used in several of the rheumatic diseases, including rheumatoid arthritis, as well as the axial spondyloarthropathies. Side effects are wide-ranging again and include bone marrow suppression, nausea and vomiting, photosensitivity reaction, a skin rash, headaches, as well as an orange tinge to the tears, urine and sweat. There may be also a risk of transient azoospermia. This should not be taken by people with an allergy to sulfonamide medication, for example, trimethoprim. This drug is safe in pregnancy and breastfeeding. The next drug is hydroxychloroquine, which blocks the toll-like receptors on plasmacytoid dendritic cells and originally was a treatment for malaria. This drug is used in the treatment of lupus, most commonly, as well as rheumatoid arthritis as one of the DMARDs. In terms of monitoring requirements, there are no regular blood tests required for this drug. However, eye examination is usually performed prior to treatment and certainly after 5 years of use as per the BSR and Royal College of Ophthalmologists guidelines. The reason for doing this is to perform an optical coherence tomography scan to check for any retinal damage. This drug is safe in pregnancy and breastfeeding. Leflunomide is an inhibitor of dihydroorotate dehydrogenase, which modulates the synthesis of uridine monophosphate. A classic use of this drug is in rheumatoid arthritis. The side effects of leflunomide are wide-ranging and include a rash, temporary hair loss, liver toxicity, nausea, diarrhea, weight loss, abdominal pain, hypertension, and bone marrow suppression. The monitoring requirements include regular LFTs, as well as blood pressure monitoring when in clinic. This drug is not safe in pregnancy or breastfeeding. Azathloprine is an inhibitor of purine metabolism and may inhibit DNA or RNA synthesis also. This drug is used in several conditions, including rheumatoid arthritis and lupus. Side effects include bone marrow suppression, nausea, vomiting, decreased appetite, and liver toxicity. Regular blood tests are required, particularly when first starting the drug and increasing the dose. And it's important to remember in the context of a rheumatology patient that there is an interaction with allopurinol. So, for example, if somebody has both gout and lupus, then it would not be advised to prescribe both of these drugs in the same patient due to the risk of pancytopenia and an adverse reaction. This drug is safe in pregnancy and breastfeeding. Cyclosporin is our next drug, and this is an inhibitor of T lymphocytes. And a classic use of this would be in rheumatoid arthritis. Side effects include swelling, kidney damage, hypertension, hirsutism, nausea, diarrhea, as well as indigestion. Monitoring includes blood pressure and checking renal function. So now it's time for some questions. Question 1. A 30-year-old lady with a history of rheumatoid arthritis treated with methotrexate presents to her GP with a UTI. She is prescribed a short course of antibiotics. 3 days later, she presents to her local hospital with profound lethargy, nausea, and malaise. Blood tests show a pancytopenia. Which of the following antibiotics was she prescribed? So the options are nitrofurantoin, ciprofloxacin, coamoxiclav, trimethoprim, and pivmecillinum. The correct answer in this case is trimethoprim, and this is due to the adverse reaction between trimethoprim and methotrexate. Question 2. A 45-year-old lady with a history of rheumatoid arthritis presents to A&E with acute worsening shortness of breath and a dry cough. She is diagnosed with pneumonitis. She was started on a new treatment for her rheumatoid arthritis 2 weeks ago. Which drug is likely to be the cause of her presentation? So the options are methotrexate, sulfasalazine, hydroxychloroquine, leflunomide, and azathloprine. The correct answer in this case is methotrexate, which can cause a methotrexate pneumonitis in rare cases. Question 3. A 25-year-old lady with rheumatoid arthritis is on methotrexate. She wishes to become pregnant. Which of the following is a safe option for her during pregnancy and breastfeeding? So your options are methotrexate, hydroxychloroquine, leflunomide, ibuprofen, and naproxen. And the correct answer in this case is hydroxychloroquine, which is the only pregnancy-safe medication out of those 5. We will be talking further about ibuprofen and naproxen in a later episode. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.